Welcome everyone. Thank you for joining us tonight. This evening we're going to be talking with Sara Levene from CRGH, who will be discussing the role of genetics in the counselling in the IVF journey. So I'm Eloise. I'm the founder and CEO of Fertility Help Hub. I went through my own infertility struggle 5 years ago with my husband, who is infertile. We have sperm donor conceived children. So this topic is really something that I resonate a lot with. And Fertility Help Hub encompasses and gives everyone everything that I wish that we had had in one place. And welcoming our guest this evening, Sara Levene.
Hi, I'm Sara and I'm a genetic counsellor currently working at the Centre for Reproductive and Genetic Health, CRGH, where I've been for a few years. And before that, I spent many years, about 18 years at Guy's Hospital in the genetics department and the PGD service there. So at CRGH, I mainly work in PGD, pre-implantation genetic diagnosis, but also offering various genetic tests and genetic counselling to the IVF patient group that we have in our clinic, and developing further genetic programs that we have as well. And I also sit as the vice chair of the UK Association of Genetic Nurses and Counsellors, and I advise a couple of different medical charities as well. So I've got quite a broad overview of different genetics areas, although obviously I specialise in the fertility side of it. I'll be telling you a bit more about that. So I'm gonna need to start off with a little bit of a biology reminder, because it does help us if we all know what we're talking about. So just to give you some definitions that you probably know already, but genes are the instructions that tell our body how to work. There's about 20,000 of them. So there's a lot of complicated instructions, and let's be honest, we don't know what all of them do or how all of them work at the moment. Still lots of research to do. Now these genes are packaged in long strings called chromosomes, and in the picture you can see the sort of chromosome is that I don't know if when I move my mouse, if that shows up for other people. Does that show up, Eloise?
No, it doesn't.
Oh, okay. So I can't do pointing for you, but at the top there's a little word that says chromosome, and underneath it, that's right. Thanks, Eloise. That's the chromosome. And then what you can see coming down kind of from that is it being unraveled into a long sort of wound up string of DNA that's being unraveled through the picture into its coding sequence. So basically a chromosome is a tightly wound up string of DNA, and the genes are along that string of DNA, a bit like beads on a necklace. Each bead is a gene and the whole necklace would be a chromosome. And we have actually 23 pairs of chromosomes, so 46 altogether, that contain all of this genetic material. So they come in pairs because the two copies come to us, one from each of our parents, and we pass on one of each pair to a future child, as does the partner, the other parent, and that's how then the next generation also have two copies, and how each generation is an equal mix of their two parents. So when we come to talk about genes and chromosomes, I'm going to be talking about both those terms, but it's important to always remember that there's two copies of everything and we only pass on one. So that makes a big difference to lots of things. Okay, that's our little bit of biology. So moving on. We're going to talk about all the different kinds of genetic tests that are being used these days in fertility clinics. And these I've divided up according to sort of who the test is done for and when. So there are tests that are being done in the early stages of the assessment of fertility for the couple themselves. There are also tests that are done on embryos these days. And once somebody hopefully gets pregnant, there may be genetic tests offered then as well. So we'll talk about some of those. So let's start with the genetic tests that are offered for the couples. So some of these are just routine tests that are offered for different kinds of fertility questions that people might be asking. So for example, if you have previous history of miscarriages, or you've already had IVF and you haven't had successful implantations, one genetic test that could be offered to you would be karyotyping. And that means that they look at those chromosomes down the microscope and see the structure of them. They'll do that test for both members of the couple. And what they're looking for is if there's been any rearrangement in the structure of the chromosomes, and if it's the type that we call balanced, which means that the person themselves that carries the change in the structure of the chromosomes is completely healthy. They don't know that they've got this problem, because being balanced means that nothing's been lost or gained from the DNA. All of the material's there, it's just in a different order. And so you'll be healthy if you've got that. But if you pass it on to an embryo or to a pregnancy in an unbalanced form, which can happen by accident as it gets passed on, that can cause higher risk of either the failure of implantation of an embryo or of miscarriage. So that's a common type of genetic test that's done for in a fertility clinic. And then the other particular reason why genetic testing often gets done in fertility clinics is for men who have low sperm counts or have no sperm. And there's a series of 3 genetic tests that are commonly done for those men. One of them is looking at the cystic fibrosis gene, which I think sometimes surprises people, because if you know about cystic fibrosis, you'll know that it's a lung disease in children and affects the mucus in their lungs. You might think, why is that being done for men who have low sperm count? And that's because there's a variation of the cystic fibrosis gene, which for most people who have it doesn't cause them to have any lung problems, but actually causes those men who have that gene variation are missing the vas deferens tube that delivers the sperm. And so it might be why there are no sperm in the semen. Actually, for those men, there's usually sperm in the testes. They're just not making it out because there's no tube to deliver them. So sometimes if there are no sperm, then a cystic fibrosis test will be done to see if that particular type of gene variant might be the cause. Another reason why you might have low sperm would also be these kinds of chromosome rearrangements that we talked about, which can cause recurrent miscarriage. Men who carry chromosome rearrangements may have low sperm production, not always, but sometimes. So they will check that for men with low sperm count. And then the other one is that when we talk about chromosomes, mostly these chromosomes, I said there are 23 pairs and they're just numbered from 1 to 22, biggest to smallest. But the 23rd pair are the X and Y that make us male and female. And men have an X and a Y and women have 2 X's. And for men who have low sperm count, sometimes the reason for that is that there's actually a section of the Y chromosome missing. So they do a screen of the Y chromosome looking for deletions in men with low sperm count. So those are some of the routine genetic tests that are done. And these are not done by myself, a genetic counsellor. These are being done routinely by IVF doctors who are assessing couples who are asking questions about fertility. But they do have obviously genetic implications. So that's the first category of tests.
Could I ask you something, Sara, at this point? Yeah, sure. My husband has Klinefelter syndrome, and so he has an extra chromosome. Could you tell us a little bit about that? Because we went from, having a diagnosis of 0 sperm, azoospermia, to then being hurled into genetics testing.
Right, yeah, exactly. So that's the kind of thing that would be revealed on a karyotype test for a man with a low sperm count or no sperm, because a karyotype counts and looks at the structure of the chromosomes. And as you say, Klinefelter's is when there is a whole extra copy of the X chromosome. So I said before that the X and Y make us male and female. And so women have 2 X's typically. Men typically have an X and Y. But what can happen is that you can have variations in the number of your sex chromosomes, of the X's and Y's, without it changing your gender or your sex in any way, but it just can affect things down the line like fertility. So Klinefelter's is when you have 2 X's and a Y. The presence of Y chromosome material makes somebody male. The fact that there's an extra X doesn't make you any less male, but it does affect the production of sperm. So, and then there can be a few other things that can be impacted for men who have an extra X, but they're not usually serious health problems. But that's something that is revealed on a karyotype.
And how common are these? Is the detection of this?
So I can't remember the exact figures for Klinefelter's. I think it's 1 in several thousand men who will have that. But generally speaking, when we talk about all different kinds of chromosome rearrangements that can occur or changes in chromosome number, I suppose about 1 in 500 people in the population might have some kind of change in their chromosome number or structure.
Okay, thank you. We have so many readers who have just had, Klinefelter diagnosis and other diagnoses. So it's really interesting to hear why this may occur.
Yeah. And it's one of those things that happens randomly at kind of the conception of that male. At his conception, there would have been just an error in the chromosomes in the egg or sperm that made him. So it's not something that's inherited from either of his parents. There wouldn't have been anything about their chromosomes that predisposed to this. It just is a one-off mistake.
And if that person was then able to have a child themselves, would there be any chance that their child would have a similar arrangement?
Well, that's an interesting question. And we don't have a lot of data on it because only a small number of men with Klinefelters have enough sperm to actually use in treatment. So there haven't been that many children born to people. And bearing in mind that technologies to even do that have been only fairly recent. So mostly in the past, people with Klinefelters just didn't have their own children at all. And the small number of men who have managed to, in current times, it's not a big enough data set, really. What we think is that, what one theory is anyway, I should say, one theory is that for men who do have some sperm in the testes when you do a surgical sperm retrieval, when they have Klinefelters, if you've got enough sperm then to use in IVF, it might be that there's a population of cells in the testes that have normal chromosomes that are the ones generating the sperm, because the population of cells with the extra X would be quite unlikely to generate sperm or generate normal sperm that could be used. So one theory is that actually you don't have a very high risk of chromosome errors in the next generation because those sperm probably arose from a small population of normal cells. Some people think that there might be a very slight increased risk of chromosome errors, and that could be another case of Klinefelters, but it could be something else where there becomes, because it generates just a sort of imbalance in general as chromosomes get passed on. So you could have an extra X for a girl, which would cause a triple X syndrome, which is something different, or a missing X in a girl, which would cause a syndrome called Turner's, or it could cause something else. We don't always kind of know what to predict there, but we think that some people think it could be a slight increased risk, but it wouldn't be very high.
Okay, that's interesting. Thank you.
Okay, so this is another kind of genetic testing which is starting to be used in fertility settings, but not just in fertility settings. And the official name for it is extended or expanded carrier screening, which people sometimes shorten to ECS. At CRGH, we have our own trade name for our test, and we call it carrier match. And what it is actually nothing to do with fertility. It's a genetic test which could be used by anybody prior to conception to just assess whether there's any risk that they would have a child with a rare genetic condition. So it's not to do with whether or not they can have a child, whether or not they can conceive. It's just that every so often a child is born with a serious health problem, and people might want to find out if they're a particular risk of that before they start their family. And particularly, we're finding that couples coming into an IVF clinic are often more interested in that kind of screening than perhaps couples who are just having children without thinking too much about medical stuff, especially because if you are going to be having a lot of expensive invasive treatment to even create a child in the first place through IVF, it becomes, so much more I suppose people are thinking much more about getting the best possible kind of outcome from that, and not only to have a child, but to make sure as much as possible they're maximising the chance of having a healthy child, which obviously everybody wants, whether or not you're having IVF. But I think people just don't think about these things until sometimes they're in an IVF setting. So anyway, it's a test that would be done prior to conception to anybody who wants it before they have children. And in our case, we have a panel of about 500 genes for rare genetic conditions, which we're looking to see if people are healthy carriers. And I'm going to tell you a bit more about what that is in a minute. The technical term is that these are recessive genes, and there's also some other types called X-linked genes, and I'll tell you a bit more about that. But basically recessive genes, because as I said to you at the beginning, we have 2 copies of every gene, it's normal for everybody in the population, the whole world, we all carry some 40 genes that are recessive. And because they're recessive, it means that we don't have any effect from that 40 gene. Well, it means that one copy of the gene is faulty, but the other matched pair of that gene is working fine. And so when you have a faulty recessive gene, the working copy does the job instead, and you don't know you carry it. The issue is that if 2 members of a couple, 2 genetic parents, both happen by chance to be carriers of the same faulty gene, when they pass on to their children, if they both pass on that faulty gene and the child then has no working copy, they have 2 faulty copies, they could then develop that disease. And so there's lots of rare genetic diseases that arise that way. And that's what the main category of genes that we test for on this carrier match panel, on the expanded carrier screening that's done. What we're not looking for are genes that cause diseases in adulthood, or what we call dominant genes. So that's things like cancer susceptibility genes, genes that might cause things like adult onset heart disease or adult onset dementia and things like that. None of that's on this test. This is about childhood diseases. Now, these tests, I say, are often big panels of large numbers of genes. They don't give you 100% reassurance that you can't have a baby with one of these diseases, but they give you a lot of reassurance that we've ruled out most of the common mutations, the spelling mistakes in those genes that we know cause those diseases. But what you're left with at the end, which I've written here, is a residual risk. So there'll always be a very small risk after you get a normal result for any of these genetic tests that you might have a mutation, a spelling mistake in the gene that the test can't detect. So it's not that it gives you a 100% guarantee. And anyway, it's 500 genes and we've probably got 20,000. So there's no genetic test that can give you a guarantee of a healthy baby, of course. But what we're doing here is gradually reducing these risks by finding out more and more. And then that allows people some choices, because in the unlikely event that a couple happen to both carry the same faulty gene, then they do have options. For example, PGD, which is an area I work in, pre-implantation genetic diagnosis, where we actually test the embryos for that and select the healthy embryos. And we can talk more about that later. Obviously, when people find out they carry a faulty gene, that can have implications for their relatives who might also be carriers. So we do suggest to people they might want to inform, say, brothers and sisters or even cousins who are at the age for starting a family. And the other big area where we're using this screening is people who are using donor sperm and donor eggs, and we can talk about that more in a minute. But if we just go to the next slide, please. I just wanted to show you a little bit more about it. So some of the common genes that people might have heard of for recessive screening are on this list. Now, there's, as I say, 500, so many that you'll have never heard of, but these are probably the most common. And the carrier frequency, so how many people are carriers of these genes, varies hugely. But let's say cystic fibrosis in the white European population is carried by about 1 in 25 people. Whereas if we look at some of the most rare genes on our panel, they're going to be carried by 1 in several hundred people. So there's a big range in how common these genes are, but it only matters when both members of a couple are both carriers. And then down there, Fragile X and Duchenne muscular dystrophy are examples of genes that we call X-linked, which is a different description, which I'm going to tell you about in a minute. But just going back to the recessive genes, if we go to the next slide, please. So just to show you how recessive genes are passed on. So when two parents both carry the same faulty gene, so that's the carrier father and the carrier mother in this picture, you can see the different combinations of genes they can pass on. So there's on the bottom left a 25% chance that they could actually both pass on their normal gene and have a child who's not even a carrier, even though. Then there's a 50% chance that they could have a child who is a carrier like them, because either the child inherits the father's gene or the mother's gene plus a normal one from the other parent. Or if they both pass on their faulty gene, then the child would be affected with that rare genetic disease. So we're doing carrier match because what we're looking for with this 500 gene panel is whether a couple are matched for the same recessive gene and then are at 25% risk of having a child with that disease. So that's the expanded carrier screen. We're also using carrier screening for people who are using, especially at the moment, women who are using donor sperm. This may well start to apply to people using donor. At the moment, what we've found is that especially outside of the UK, especially in America, the sperm banks are doing these kind of expanded carrier tests on the donors before they give their sperm. And because, as I said to you, everybody carries some recessive genes, it typically, you will find if you look now at the profiles of sperm donors at American sperm banks, that each one of them comes with a list of what genes they carry. Usually they carry at least one recessive gene from the panel they've been tested for, but sometimes they carry several. There are some donors who don't carry any of the genes they've been tested for, but obviously any of the panel tests that these sperm banks are using will be however many 100, 200, 300, 400, 500 genes, just like we've got 500 genes on our panel. Each lab will have its own panel, which might have a different number of genes on it. And if a donor has none of those genes, that doesn't mean that they're not a carrier of a recessive gene. It just means they don't carry any of the genes on the panel. They'll probably carry something else, because we all carry something. But then you see what happens is that because the women the couples who are choosing sperm donors are being given these lists of genes that the donors carry, it's then becoming an issue for those women and those couples to find out if that then makes a risk for the future child, meaning genetic testing embryos. Right, let's do this. So we were just touching on that when I was answering one of our questions about PGS, pre-implantation genetic screening, which is the general chromosome testing. So that requires us to biopsy an embryo on day 5 or 6 when it reaches blastocyst stage, taking a few cells, typically around 5, could be up to 10, from the outer edge of the embryo and extracting that DNA. And then usually for most people in IVF clinics, the reason that would be done is for PGS, so generally counting the chromosome number. And as I said when I was answering that question before, the main reason for that is that we know that embryos that have the wrong number of chromosomes are very unlikely to implant. And if they do, they could well miscarry, or they could be at risk of causing a baby to have a syndrome. So that's the reason for PGS. It's basically to help us select the embryo with the best chance. And then the other reason why you might be biopsying embryos and taking cells for DNA extraction and testing would be when there is a known familial genetic condition, a mutation in a gene, or a rearrangement of the chromosomes that is a risk of being passed down from the parent to the embryo. And that is called PGD, pre-implantation genetic diagnosis. It's the main area I work in. And it's got some new acronyms of PGTM, pre-implantation genetic testing for monogenic conditions, meaning a single gene error, or pre-implantation genetic testing for structural rearrangements, PGTSR, which is that when there's a change in somebody's chromosome structure. So those are the different kinds of reasons you might test embryos. Typically, when an embryo has been biopsied for this test, it has to go into the freezer while you wait for the results, because they can take anything from days to weeks. And so you can't leave them in an incubator all that time. So it means that when you're having any sort of testing of embryos, you're going to be looking at frozen rather than fresh transfers of embryos in the future. Assuming you've got embryos with normal genetic results at the end. And then if we go to the next slide, just talking about the that's a picture of embryo biopsy, so you can see them under the microscope. So you can go to the next slide then.
I can.
Yeah, so that's a picture where we the embryologists, I'm a genetic counsellor, not embryologist, makes a little hole in the wall of the embryo and sucks out a few cells from the edge. That's what you can see in that picture. So if we go to the next slide, can we go to the next slide? Okay, so we've been talking about PGS, and as just one thing to flag up that I haven't said already that's on this slide, a couple of things to flag up. Firstly, that the errors that we find in chromosome number in early embryos are not inherited from either parent. Typically, the parents have normal chromosomes. This is just something that's happened as a one-off mistake at the conception of that embryo in either the egg or the sperm. But typically, we find that as women's eggs get older, you get more chromosome errors happening. It's just a kind of a function of, as we get older, things start to go wrong a little bit in our bodies, and one of those things is that we get more chromosome errors in our eggs as women get older. And so typically with PGS it might be offered more often to couples where the woman is a later age, and that's where you will also find more abnormal embryos, unfortunately. If you go to the next slide. And this is a picture of the chromosome. So we've been talking about the long strings, and I showed you kind of at the very beginning one chromosome. But then if we look at them in their pairs laid out from 1 to 23, although the 23rd pair is not numbered, it's XY, you can see in this picture that there, in that little red box, that there are actually 3 copies of chromosome 21 where there should have been 2. And this embryo would have Down syndrome. And this is the kind of thing that can be detected on PGS. But equally, you can detect any other similar problem with another chromosome, either a missing or added copy. And any of those things, although they may not cause a syndrome, mainly the reason they don't always cause syndromes is that most chromosome errors are too big for an embryo to actually even develop and get that far. It means that the embryo just doesn't ever implant, or if it does, it miscarries. And there's only a handful of chromosome errors that are compatible with live birth, with an embryo developing and being a baby, because mainly they're too big. The problems are too big for the baby to develop. So that's why we're counting the number of chromosomes. If you go to the next slide. Now, there's obviously both pros and cons to anything. And with PGS, it's getting more and more common in IVF clinics, but there is still some controversy and some people who are not sure if this is a great idea. And the biggest things that are being discussed about that are to do with something called chromosome mosaicism. So a mosaic embryo is when the population of cells in the embryo are a mixture. Some of them have got normal chromosomes and some of them have got chromosome errors. So you've got two kinds of cells in the embryo. And then the question is, when you take a sample of just 5 cells from the embryo, how do you know that those 5 cells truly represent all the cells in the embryo? And what if you've picked up an abnormality, but it's only in a small population of cells and the rest of the embryo is normal? And actually, could you be unnecessarily discarding an embryo that's found to have a chromosome error where actually it's not in all of those cells? You don't know that. You can't see all of the cells. You can only see the ones you've got in the biopsy. So that's one question that's being raised about PGS. And there's research being done now on that. And in fact, there was a really interesting study that just came out recently where they didn't do PGS. They just transferred embryos in an IVF clinic without doing testing. I think they biopsied them, but they didn't do a test. They kept some DNA. They did the transfer to see if a pregnancy developed. And then afterwards, they looked back at the DNA from the embryos to see what those chromosome results were. And what they found was that the embryos that actually turned out to have had chromosome abnormalities, none of them made pregnancies from the DNA that had been taken. So that although we think there is, and we know that mosaicism exists and that some embryos do have mixed cells, we do know that when an embryo has abnormal chromosomes, it's very unlikely to make a pregnancy, and that's being shown more and more from the data. And I think the hardest thing for couples who have PGS is when they have no embryos for transfer because they're told that all of their embryos have different chromosome errors, none of them can be used. And seeing all of their embryos sort of being discarded in that way is extremely upsetting. And I think we have to think about what the psychological impact of that is. We also have to think about the financial burden of that on patients, because that might mean that you're then offered another cycle to try again and find more embryos so that we could find some with normal chromosomes in the next batch, hopefully. But obviously that might mean having even more treatment than you'd expected when you started out. But on the good side, as I said, what we do know is that when you've got an embryo with a normal chromosome result, the pregnancy rate per embryo transfer is much higher than either untested embryos or certainly embryos that are abnormal that don't usually make a successful pregnancy. So what we do find with PGS is if you have that, you do tend to have higher chances of a pregnancy if you make it to the point of having an embryo transfer. And of course, fewer miscarriages, although there are plenty of other reasons for miscarriages that PGS is not detecting, but it rules out one cause of miscarriage, the chromosome errors. And that overall, the theory goes that the advantage of PGS is the reduced time to get to a successful outcome from your IVF, because let's say you've got a batch of 5 embryos from your IVF cycle and you haven't tested them. So now what you're going to do is one by one do frozen embryo transfers. Well, you could spend months, years sometimes going through the process of subsequent embryo transfers. And if you had within that some that have got chromosome abnormalities that never were going to make a pregnancy, well, if you knew about that from the beginning and you could zoom in on the embryo that's got the normal chromosomes from the beginning, then you're going to get much quicker to the point where you're using an embryo that's going to give you a good chance of success. And that's the idea of it, is to kind of rule out the embryos that just never got a chance and get us to the ones that have got a chance quicker. And that's where people see the advantage. But, you know, it is important to look at all sides of these things. If you go to the next slide. So I just got some data. This is CRGH's own data, and just to show you about how chromosome abnormalities increase in frequency with female age, unfortunately. So what you can see there is that the normal ones are the blue part of the bar. So below the age of 35, more than half of your embryos have normal chromosomes. And by the time you are in your late 30s and 40s, you're going to find most of your embryos have abnormal chromosomes. So there's only a small number of embryos in any batch that have normal results as you get older. So that's why PGS is being offered more to older women, because we want to zoom in on the embryos that do have the normal chromosomes. Next slide. And this is just to show you from CRGH's data of the impact of doing PGS on our success rate. So what you can see here is that, so this is CPR is clinical pregnancy rate, So that's when, you know, people having a positive pregnancy test. LBR is live birth rate. So when you get a positive pregnancy test, that doesn't necessarily mean that you'll have a baby, because there could be a miscarriage for another reason. So the difference between the dark blue and the light blue is, the dark blue is the people that had a positive pregnancy test, and the light blue is the people who had an actual baby. And the blue group are the people who didn't have PGS, and then the pink group are the people that had PGS. I don't know where my color coding has gone for the graph, but anyway, so the pink group are the people who had PGS. And so you can see that both the clinical pregnancy rate and, more importantly, the live birth rate in each age group, apart from the youngest, where there aren't that many, the below 35s don't have very many chromosome errors anyway, so there's not any usual significant difference there. But once you get above the age of 35, you'll have a higher number of babies born for the pink than the blue, and that's because we've selected the embryos that have got normal chromosomes from the start. So that's the impact of PGS and why we do use it, despite knowing that there are some drawbacks. Okay. We mentioned earlier PGD, so that's the genetic testing of embryos for a known risk that might exist in a family. So I explained to you already about recessive genes and X-linked genes. I mentioned other kinds of genes called dominant genes that also are sometimes genes that are passed on in families. And that's all of those are the PGTM category, so monogenic or single gene mutations that are causing disease. Then there's, I mentioned before, some people have a rearrangement of their chromosomes for which we can specifically test embryos. And really all of this is kind of originally started as being an alternative to prenatal diagnosis, because from the point of view of genetics, this is actually, PGD is much more being offered to couples who are not attending the clinic because of a fertility problem. They often are fertile and could conceive naturally themselves if they wanted to, but because of the genetic risk, their only option if they conceive naturally is to do genetic testing of the pregnancy itself. So that's where you put a needle through the woman's belly during the pregnancy, like an amniocentesis that you might have heard of. And then, you know, if you do that test and find that the excuse me, find the pregnancy is affected with the condition, the only option then is a termination of pregnancy if you don't want to be at risk of having a child with that disease. And of course, that's a very difficult position for people to be in. So by having the genetic testing done of the embryo before the pregnancy, you avoid being in that situation. And that's really how this came about. And as I say, most of the couples having PGD and have not got a fertility problem, they're coming to us to avoid being in the situation of prenatal diagnosis and termination of pregnancy, so that they can start out their pregnancy knowing that they've avoided their genetic risk. And in most of these couples, they already know they've got a family history of a serious genetic condition, either in their history, their parents or their siblings or other people in their family are affected, or themselves, one member of the couple affected, or they've already had a child who's been diagnosed with a rare genetic condition and they want to avoid it happening again. And there are some people we're discovering through our carrier match screening who have a genetic risk and then have PGD who don't have previous family history. So that's the pre-implantation test. Now I feel like we're going to be running out of time for my slides if I want to leave time for questions. So just moving quickly on. I'm just going to quickly touch on one type of test that is available, a genetic test that's available in early pregnancy. And that's something that's relatively new on the scene, although you may well have heard of it by now. And it's called NIPT, or non-invasive prenatal diagnosis. And it's basically an early form of Down syndrome screening. Again, it comes back to counting chromosomes, which we've talked about a lot. Down syndrome being the most common chromosome error, where you've got a third copy of chromosome 21. And when there's 3 copies of a chromosome, we call it a trisomy. So trisomy 21 is another name for Down syndrome. And normally, well, previously in the past, you could only find that out for sure by doing something like an amniocentesis where you got a sample from the pregnancy. But now we know that when a woman is pregnant, fragments of DNA from the pregnancy make it across the placenta and back into the woman's bloodstream. And you can actually extract fragments of DNA from the pregnancy from the woman's own blood. And that's enough DNA for us to detect if there is too much material present for chromosome 21 and to detect Down syndrome in a woman's blood at about 10 weeks. We can also use it for sort of about 3 or 4 other similar chromosome errors. And that's becoming more and more available, both in private clinics and also in some situations in the NHS as well now. So that's an early pregnancy genetic test, which is quite common.
Well, thank you so much, Sara. Thank you everyone for joining. I think that concludes the webinar tonight.